Hello and good evening, good afternoon and good morning, everybody. I am Dr. Mohit Bhandari from Indore in India, and I welcome you for yet another episode of the Virtual Bariatric University, an initiative, a training program, a webinar started by myself and Professor Fobi. This is the 17th episode, and today we have a very interesting topic which denotes that as bariatric surgeons, we are not only interested in just operating our patients, but we also understand that there exists a non-surgical treatment of obesity and the choice of patients and the operations in bariatric metabolic surgery. We have with us Professor Scott Shikora from USA. I think Professor Scott does not need any introduction, but I would still do that. Professor Scott is the director of the Center for Metabolic and Bariatric Surgery in Brigham and Women's Hospital and professor of surgery at the Harvard Medical School. Dr. Shikora has been named as one of the Boston's best doctor by the Boston Magazine. Dr. Shikora is both a past president and former executive council member of ASMBS. He is also an associate editor of SORD and the current editor-in-chief of obesity surgery. Dr. Scott Shikora has authored numerous book chapters, journal publications, and has made hundreds of publications in field of bariatric and metabolic surgery. Myself and Professor Fobi, we have a very long relationship with Scott. We are so proud of his achievements, and today we are honored to have him at this show as one of our main faculty. Scott, welcome to Virtual Bariatric University. Next, we have Cynthia, one of my friends. Cynthia Borg is from UK, and she is a consultant upper GI and bariatric surgeon at University Hospital in London. She is also the regional surgical advisor for London to Royal College of Surgeons in Edinburgh, and an elected council member of BOMS. Cynthia is very young, dynamic, one of the most vibrant bariatric surgeons, and we enjoyed the IFSO World Congress she did, and where we were hosted in 2018, and she did a great job, and we all enjoyed this meeting. So Cynthia, welcome to the Virtual Bariatric University. We have Professor Alaa Abbas from Egypt. Professor Alaa Abbas is a professor of surgery and the past head of bariatric surgery unit at Ain Shams University, and is also the president of the Egyptian Society for Bariatric and Metabolic Surgery. So Alas, welcome to the Virtual Bariatric University, and we look forward to have your wisdom here on this show. Then we have this evening Dr. M. Kermansaravi from Iran. He is the assistant professor and did his fellowship in bariatric and metabolic surgery. And now he is in the Department of Surgery, Rosel Akram Hospital in Iran University in Tehran. He is also reviewer in the Obesity Surgery Journal and several high impact journals. So welcome, Dr. Kermansaravi, and we look forward to listen to you and to have your views on the show. I'm pleased to have one of my friends and another great surgeon from Singapore, Asim Shabbir. Asim is a senior consultant in Division of General Surgery and Department of Surgery with National University Hospital in Singapore. And he's also a senior consultant in the Division of Surgical Oncology in the same university at Singapore. He's a senior consultant at the Alexandra Hospital and the deputy head Department of Surgery at National University Hospital and Center for Obesity and Metabolic Disorders in the same university. So welcome, Asim. And I think you have been for the first time at this show. I hope you enjoy the Virtual Bariatric University, and we will have you for our future courses as well. Another friend from India, very young, very dynamic, very vibrant, Vivek Bindal. He is a bariatric, metabolic, and robotic surgeon from New Delhi. He's a vice chair at IMAS Sir Gangaram Institute in New Delhi. He also is one of the most instrumental and founder members of the CRSA and runs the CRSA, the Clinical Robotic Surgery Association show in India. He's on the editorial board for SORD and is a sectional editor in the Journal of Minimal Access Surgery. Welcome, Vivek, to the show. And we look forward to have you here and to listen to your views on this topic. One of my fellows and now a consultant, the most talented Prashant Salvi from Mumbai in India. Prashant is at present a consultant in minimally invasive bariatric and metabolic department in Jupiter Hospital in Thane in Pune. He did a fellowship under us and he was one of the most bright fellows we had at Mohawk Hospital. He also did a fellowship with IIGS in advanced laparoscopic surgery and did a fellowship in minimal invasive surgery with the Maharashtra University of Health Sciences at Jupiter Hospital in Thane. So welcome, Prashant. He will be presenting the data from our center, and I'm so proud to have you on this show. Last but not the least, myself and my mentor, Professor Fobi, we run this virtual bariatric university to disseminate knowledge, skills, and the experience of leaders like the ones are on the show to the world around. Without much delay, I would like to invite Alaa Abbas, Asim, and Kermansaravi to, along with Professor Fobi, to moderate the first lecture session. Thank you very much.
Dr. Abbas.
Hello, everybody. I would like to thank Professor Fobi and Professor Bhandari for their effort. They have done this for this 17th time, and everybody is benefiting from their work all over the world. And we are really honored to share with their activity today. I'm presenting the first speaker, Dr. Vivek Bindal. He is the Vice Chairman of the Institute of Minimal Access Metabolic and Bariatric Surgery at Sir Ganga Ram Hospital, New Delhi. And his talk is going to be about the non-surgical treatment of obesity, the lifestyle modifications, diet, and pharmacotherapy. Dr. Vivek, please start.
Thank you, Professor Abbas. Thank you, Professor Bhandari and Professor Fobi for making me a part of this August forum. It is a real pleasure to be sharing the dais with leaders from across the world and talking on this topic of non-surgical treatment of obesity. I had to actually read because we basically are surgeons, and it made me read and I got to learn new things. So I like this topic. I bring greetings from Sir Ganga Ram Hospital. So this is my conflict of interest disclosure. I am a consultant for Ethicon, Medtronic, Intuitive, Bard, and Debron, but none of these has any influence on this talk. Pacemakes by sleeve techniques run by gastric bypasses, endoscopic sleeve gastroplasties, and divisional surgeries. So we have to see obesity as a chronic disease, and we have to have a holistic approach to it. There are multifactorial determinants of weight gain that we need to consider, and our primary aim should be the health benefits which are derived from weight loss. And foundational to any weight loss effort is lifestyle change, diet, and increased physical activity. So this is very important. Whatever intervention we do, whether it is pharmacotherapy or it is surgery or it is any kind of bariatric procedure, we need to have lifestyle change, diet, and increased physical activity as a part of it. Now, this is the American Association of Clinical Endocrinology algorithm, just a snapshot, which is talking about the primary prevention of obesity, the secondary prevention, and then the tertiary stage wherein the patient is already obese. So, basically, if the patient is in Edmonton class 1 or 2, then you will consider lifestyle changes or pharmacotherapy, and tertiary, if the patient has a higher BMI, we may go in for bariatric. So we'll come into this. By and large, obesity is a chronic disease that requires lifelong management. Drug therapy is a part of it. And there is a limited efficacy of anti-obesity medication. We need to remember around 5 to 10% of weight loss over a period of 1 year. And the weight reduction per se should not be the main goal, but the reduction of comorbid conditions associated with obesity should be. So this is the pyramid of obesity all of us see in our population. And bariatric surgery is just tip of the pyramid. Pharmacotherapy makes a larger chunk of it, and while the weight management, lifestyle interventions is the major part. So when we talk about therapy for weight loss, it is basically a high quality diet accompanied by an exercise. Now we need to identify what type of exercise, what kind of medications we should add if required, and what are the approved medications for chronic weight management, as well as endoscopic or surgical interventions or other parts. Now for lifestyle modifications, there have been 2 large randomized controlled trials, the Look Ahead study and the Diabetes Prevention Program. And what we saw was these are the 3 variables that predicted weight loss with lifestyle modification at 1, 4, and 8 years. The number of behavioral sessions attended by the patient, the number of knee replacement used per day, and weekly minutes of physical activity. So, behavior, diet, and exercise, all 3 play a major role in weight loss. And the average weight loss was around 8 kg over 1 year, which is pretty significant if you look at the comorbid conditions. Also, interestingly, the initial rate of weight loss in the first and second month predicted the weight loss at 4 years and 8 years. So the outcome of any such therapy can be predicted as as soon as 1 or 2 months into the therapy. So you can see that the 4-year percentage is dependent on the 1 month percentage. And similarly, we have seen in lower gastric bypass and the normograms which we have plotted for bariatric procedures that initial weight loss predicts the long-term outcome. Now, when we talk about diet for weight loss, basically the principle is that reduction of energy by around 500 kilocalories per day is required below the requirement. For women, it is typically 1200 to 1500 kilocalories per day diet. For men, it is 1500 to 1800 kilocalories per day. But then there are a lot of different diets come to our mind: Atkins diet, keto diet, so many diets, starvation, intermittent starvation. So is there a magic weight loss diet? Is there a diet which allows you to eat as much as you want with only the need to eat the right foods? That is a question that has been studied and has been tried to be answered. Now there was this large study with the pounds called the pounds lost study with 811 patients, and they compared diets with 20% or 40% fat and 15% or 25% protein. And there was no reported significant difference in weight loss at 6 months or 2 years. A meta-analysis of low carbohydrate diet versus low fat diet showed that both are equally effective. Whatever you take, it ultimately depends on what kind of diet, what kind of calorie intake is there. There was this systematic review from 17 diets which showed that no one diet was better. Again, another meta-analysis published in JAMA showed no significant difference in weight loss between them. So basically, the idea is to provide low energy diet with the broad principle of providing a low, a difference of at least 500 kilocalories from what is the requirement per day, which is likely to be adhered to by a patient. So, you have to be very cultural, you have to be patient specific. The diet cannot be a general diet. The patient should be able to adhere it for a long time, and it should provide health benefits. So that is a very important thing. It should be, it should not be a very costly diet. It should not be something if the patient is not used to eating. So you have to make the diet depending on what the patient is eating. Something called very low calorie diet defined as having 200 to 800 kilocalories per day. It leads to more rapid loss of body fat and weight, and it can rapidly normalize blood glucose. We use it before bariatric procedures also sometimes. Now, but as a weight loss diet, the weight change after 1 year does not differ much, whether you use a very low calorie diet or you use a low calorie diet. So it is only to be considered if rapid weight loss is clinically necessary, as before a bariatric procedure for some other procedure, but not for the long-term maintenance. Coming down to physical activity, another important part of this, we should have a goal of more than 115 minutes per week of activity, and this has a lot of benefits for general health independent of weight loss. So even if there is no weight loss, if a person is physically active, there's a lot of benefit to his general health. And the type of physically the physical activity, aerobic versus resistance, or high intensity or low intensity. It can actually be dependent on what kind of patient, what kind of acceptability the patient has, what is his preference, and what can he sustain. But it should, whatever is done should be sustained. Now, anti-obesity medications, when do we talk about it? So these are the indications for anti-obesity medication use. Individuals who fail to respond to lifestyle interventions after 6 months of treatment, or people who have BMI of more than 30 kilograms per meter square, and individuals who have more than 27 kilograms per meter square BMI with associated weight loss from obesity. So, either more than 30 BMI or BMI more than 27 with associated comorbid conditions. Now, again, we have to combine diet with the lifestyle interventions also along with pharmacotherapy. So we cannot just give a pill and say that it is okay. So this is a study which shows that the combination of diet and pharmacotherapy works much better than just diet or just lifestyle alone. These are the anti-obesity drugs. Some of them, like fenfluramine and dexfenfluramine or sibutramine, have been withdrawn. Now the latest to be withdrawn was norcasterin. While we have orlistat, liraglutide, fentanyl, topiramate, and bupropion as yes FDA approved drugs. Orlistat, liraglutide, we don't get the 3 mg one, but we get the 1.8 mg for diabetes, which we use for obesity also as an off-label use. So these are the mechanism of action of various centrally acting anti-obesity drugs. A pretty busy slide here. The opioid receptors or selective serotonin uptake. So let us talk about it one by one. So if we talk about liraglutide, liraglutide is a GLP-1 analog, and it has an appetite suppressant effect. Also, it delays the gastric emptying and it leads to nausea. So it decreases the appetite and increases the satiety. While orlistat, on the other hand, it inhibits the gastrointestinal and pancreatic lipase. So it basically prevents the absorption of dietary fat. When we use orlistat, it's a pretty safe drug to use. We give it along with meals, 120 milligrams twice daily with each main meal. We typically ask the patient to take it during the meal. And again, the indications remain the same as we discussed: BMI more than 30 or BMI more than 27 with comorbid conditions. There is an adverse effect of flatus as well as oily spotting from the stools, and so basically some GI side effects are there primarily. Liraglutide, it comes as injectable, 3 milligram, or Saxenda is basically approved in US. We get Victoza in India, and it is a once daily injection. We titrate, we increase the dose slowly. So we basically start with 0.6 milligram, and we gradually increase it to 1.2 over a period of 1 week, and then next week we increase it to 1.8, and then we titrate it up to 3 milligrams. It causes less of, it decreases the appetite, increases the satiety, and it should not be given in patients with history of medullary thyroid carcinoma or multiple endocrine neoplasia, because it has been associated with thyroid tumors. Fentanyl and topiramate combination. This is fentanyl is an immediate release sympathomimetic. It decreases the appetite, and topiramate is a GABAergic drug which affects the satiety. So in India we get topiramate. We do not get a combination right now, but we basically use a combination of topiramate with hordenine here. And it has a good weight loss. It is a pill which can be taken easily, not very costly. So it is a good drug to be used. But you have to take care that some patients may develop acute glaucoma, and that can lead to acute loss of vision also. So you have to explain it to the patient very well that if there is any kind of changes in vision or pain in the eyes, you have to stop the medicine and consult the doctor. And treatment with monoamine oxidase inhibitors is something which if the patient is having MAO inhibitors, he should not take topiramate. Now, naltrexone and bupropion. Naltrexone is an opioid receptor antagonist, and bupropion is a norepinephrine dopamine reuptake inhibitor. So it is given 2 tablets twice a day, and the adverse effects are mostly GI adverse effects. So we have to be careful about chronic opioid use also. Lorcaserin was being used for last many years. 2020, it was associated with some increase in the incidence of cancers. So it has, US FDA gave a recommendation to withdraw it. It was used in the dosing of 10 milligrams twice daily. And then we basically, it was associated with some, it was generally considered to be pretty safe, but then there was this problem of increasing incidence of cancers. Now, combining weight loss medication is also something which is being done. So it is a logical therapy, and it may target different pathways, potentially resulting in synergistic effects, while there are not many studies combining them. So this is kind of a chart showing how the various pharmacotherapies or bariatric surgery can be done. So if a patient has BMI more than 30, it can be started. If there is no comorbid condition, it can be started on orlistat or naltrexone, bupropion. If there are comorbid conditions like diabetes, liraglutide is a better drug. If you can also start them on topiramate, and then in case they do not respond to these medications, we can always turn to bariatric surgery or endoscopic procedures. Now, post-bariatric weight regain or inadequate weight loss after bariatric surgery, it is a very important indication of pharmacotherapy now. And pharmacotherapy has come up as a very viable alternative to revisional bariatric, because all of us know that revisional bariatric procedures do not give us a very good weight loss, while pharmacotherapy is able to give us good results. So in this particular population, unless until there is a technical problem with the primary bariatric procedure. If the primary bariatric procedure has been done technically well, pharmacotherapy is a good alternative, and we have used it quite often in our practice also. When do we need to change our prescription of these drugs? So typically for 3 months duration, and if there is a total weight loss of less than 3% of total body weight, we should change the agent, or we should add another agent, or we should add another therapy. And combination with endoscopic therapies is a very, very viable option. So, like endoscopic sleeve gastroplasty or endoscopic balloon. Endoscopic balloon causes a lot of nausea, but good results with these medications. Dr. Bhandari helped us start an endoscopic sleeve program, and I think we are very happy with combination of endoscopic with pharmacotherapy. This is again a table showing the same drugs. So combination therapies, we can do endoscopic balloon plus pharmacotherapy, endoscopic sleeve gastroplasty with pharmacotherapy, post-bariatric surgery pharmacotherapy. If the patient is not losing enough which you want him to lose, then you can always add pharmacotherapy, 3 to 6 months down the line, and combination of medicines also. So this is just a common curve called the Rogers innovation adoption. And basically, there are innovators, early adopters, early majority, late majority, and laggards. Like Mohit is kind of innovator and early adopters. And I think all of us should try to be in this area where we should try everything safely, and we should just decide, based on how our patients are doing. And then rather than, just waiting for everything else to come. So safety should be considered first, but then we should not just discard anything and everything by hearing about it. So take-home message is obesity is a chronic disease that requires lifelong support. Pharmacotherapy is always adjunct to lifestyle changes. Combination therapies hold a lot of promise. And post-bariatric weight gain is an evolving area for endoscopic interventions as well as pharmacotherapy. Thank you so much for your kind attention. This is my mentor, Professor Ranjan Sudan from Duke University, and I always thank him for giving me insight into this field of obesity medicine. Thank you.
Thank you.
Thank you,
Abbas.
Professor Vivek. Very informative presentation. I would like to just make a comment. It's ideal that you mentioned that obesity is a chronic lifetime disease and always relapsing. And this also happens after almost all types of surgery in a percentage of our patients. And the principle and the idea of having the multiple disciplines sharing in the management of the patients for his lifetime is essential to success in all procedures and without surgery or with surgery added. And as already been mentioned many times that obesity can be mimicking cancer in management, having different types of disciplines sharing in the treatment of the patient, preoperative radio chemo, operations, and follow-up with further medications and lifetime follow-up. So we have the same principle here in bariatric surgeries that we have to get it into the plan of management, both for the team working as well as the patient and his family, that they have to understand that surgery is not a magic, it's not the magic wand which the patient, once he go through it, he will be successful. There is almost always a percentage of failure, inadequate weight loss and weight regain. And the more we appreciate the preoperative and postoperative diet modification, lifestyle modification, and sometimes the use of medication, the more successful we are and the less revisional surgeries are needed. I would like to ask you, with your presentation, do you get surgeons involved in this plan of management as early as possible, or you start off for a while with the patients conservatively if they have a BMI less than 35 with no comorbidities, or do you get the surgeons from the beginning as part of the multidisciplinary team reviewing the patient and giving him his options?
Yeah, I think that's a very important question, Professor Abbas. So how it works here is basically we run a weight loss solutions unit, and surgeon or a bariatric surgeon is the leader of the team. So we have made protocols wherein if the patient is less than 50 BMI, the patient is typically not seen by the surgeon per se. He is seen by the nutritionist and the physician, and they would start him on weight loss medication. While if the patient is above 30 BMI, then definitely the surgeon would come into play, and he would also have a look, and it would be decided along with what the patient wants. So because endoscopic therapies would start above 30 BMI in our unit, while below 30 BMI there is no endoscopic or surgical intervention that we do.
Can I ask you another question about the BMI above 30, below 35 with diabetes or simple obesity with diabetes? Again, when do you involve surgeons in the management of this group?
So again, we involve the surgeons in all these patients between 30 to 35 BMI with diabetes, and that's a very gray zone which you're talking about. About 32.5 with diabetes, we are pretty clear that we offer them a bariatric surgery. So patients with more than 32.5 BMI with diabetes are offered bariatric surgery. Between 30 to 32.5, now the recommendations say that in Indian patients, we should do bariatric or they are indicated for bariatric. But in our unit, we are still conservative in that subgroup. And we would discuss it with the patient. We would discuss the various changes that the patient has to do after the surgery. And we would try that if the patient can decrease his weight by lifestyle interventions as well as the pharmacotherapy, that is preferred over the bariatric procedure per se.
Do you have a time frame for these patients on their conservative line of treatment prior to surgery?
Yeah, so it is typically 6 months, and that is what we follow. But there is, we also do endoscopic procedures for weight loss, and some of these qualify for those kind of endoscopic procedures like endoscopic sleeve gastroplasty, and we tend to offer them that procedure also.
It used to be 2 years and even longer, but I really see your point that if the patient is not making progress in 6 months, he will not do it in 2 years. So I think persisting on the conservative treatment for patient who's not achieving any results in 6 months is good enough to start to give them advice towards endoscopic management if they are of a low BMI, or even surgery, laparoscopic, if they have a higher BMI.
Right. I think you're absolutely right on that. And we have seen whenever we see the progress of the patient, it can be very well predicted within the first 3 months how the patients are going to behave, either with lifestyle interventions or with bariatric or with endoscopy. So yes, you can kind of predict that.
Can I invite any of the panel who would like to add any questions to Dr. Vivek?
I can just make a comment. Go ahead. Go ahead.
Well, the way we deal with patients who have heart disease or vascular diseases, they get an operation and they go home on lifelong medication. I predict in the near future that we will be doing bariatric surgery and sending patients home either for long-term or lifelong medication. And I think the combination is what's going to reduce the failure rate.
Very wise comments, sir.
Yeah. That is when the primary care doctors accept obesity as a medical problem. And that's when the various payers start paying for following patients because of obesity. I think in the UK, that is probably the case since everybody's under the national health system. But in the US, the insurance don't pay for bariatric obesity management, and so that might be difficult, but that's another topic for another day. All right, Sim, let's move on to you, to the next speaker. Dr. Shabbir? Is he there? Okay. Okay, stop sharing. Himanshu, stop sharing Dr. Vidal's sheet. We'll go to Asim Shabbir. If he's not there, then I'm going to invite Dr. Cynthia Borg to make her presentation.
Okay, sir.
Okay, go ahead.
Okay.
Ready?
Hello, everybody. Thanks for joining us today. I'm Cynthia Borg. I'm a bariatric surgeon in South London. I hope you're all doing well in these challenging times. I'd like to thank Dr. Fobi and Dr. Bhandari for the kind invitation. And thank you also everybody who is behind the scenes helping us out. So today I've been asked to talk to you about the indications and the choice of operations for obesity surgery. No conflict of interest, and this is my case mix. This is what we're going to talk about today. Now, when we think about indications for bariatric surgery, probably the first thing that comes into mind are the NIH guidelines. Now, the consensus conference for these guidelines was actually held in March 1991, so that's nearly 30 years. The conference brought together surgeons, physicians, psychiatrists, nutritionists, allied health professionals, and even the public. And then once the conference ended, then they published their guidelines, and here they are. So it was recommended then that adults who have a BMI of over 40 and who have been evaluated by a multidisciplinary team with experience in obesity management could be offered bariatric surgery. They needed to strongly desire substantial weight loss because obesity severely impaired their quality of life. They also needed to have a realistic understanding of how their lives may change after surgery and that they needed long-term surveillance post-op. The NIH guidelines also asked us to consider patients with BMIs between 35 and 40, in certain instances, if they suffered from other severe problems that are related to their obesity, like obstructive sleep apnea, obesity hypoventilation syndrome, severe type 2 diabetes, and other problems that, had it not been for the obesity, would have been treatable, things like joint problems. Now, in the UK, the first set of NICE guidelines for the use of bariatric surgery as part of our management of obesity, they were first published in 2006, and then they were further updated in 2014. Now, the 2006 guidelines are certainly very similar to the NIH guidelines, but the 2014 guidelines were innovative, and they were innovative because they asked us to consider assessing patients with a BMI of between 30 and 34.9 who had recent onset type 2 diabetes. And for 2014, that was certainly an innovation. So, in terms of guidelines, while it is good that we've got national and international guidelines coming from organizations and from agencies, it doesn't necessarily trickle down to best care for patients with things like type 2 diabetes and obesity. And in order to try and get physicians and GPs a little bit more aware about type 2 diabetes and the management with metabolic surgery, the second Diabetes Surgery Summit was held in London in 2015. And after that, this algorithm for treatment of type 2 diabetes was published in Diabetes Care and in several other journals. And again, in this algorithm, we can see that even patients with class 1 obesity, i.e. a BMI between 30 and 34.9, with poor glycemic control can be considered for metabolic surgery. Now, whenever indications for surgery are discussed in meetings or in fora like this, the question always comes, what is more important? The actual BMI, the number, say 39 or 40, or what? Or is the effect on the patient most important? How they're affected both physically, psychologically, but even functionally. This is the Edmonton Obesity Staging System, and it judges the patient's clinical status. In my opinion, I think we need both, especially in a healthcare system like ours in the UK. We sometimes need both in order to prioritize patients. Now we come to some special groups of patients, and we come first to talk about adolescents. Now we know that adolescents and children are not just small miniature adults, but they have different physiological and psychological needs. The public, and unfortunately some of our physician colleagues, perceive childhood and adolescent obesity as a family or a society issue. We, however, know that adolescents or children who are obese, unfortunately, most often suffer from the disease in their adulthood, and this affects them. It affects them from an early age with physical, psychological, and functional problems. So while it is clear that bariatric surgery in this group is also safe and effective as for adults, the indications are still controversial. What there is no controversy about is the need for more support in these groups. That you need more support, more multidisciplinary support, not only for the patient, but also for their family, sometimes even for their friends and for their community. Now, looking at the adolescent guidelines, so we've got the NICE guidelines 2014, not generally recommending such surgery in this group. However, they say it may be considered in exceptional circumstances once they have achieved or nearly achieved physiological maturity. Similar to the Endocrine Society guidelines in 2017, again, they want the more mature adolescents, 10 or 4 or 10 or 5 pubertal development. They want the adolescents to comply to a pre-op formal program, and they want them to be able to adhere to the principles of healthy dietary and activity habits. Now, then we have the ASMBS guidelines 2018, the most recent of the lot. And in these guidelines, they would consider either sleeve gastrectomy or Roux-en-Y gastric bypass for adolescents, just like in adults with a BMI of more than 35 and a comorbidity, or BMI of 40. And obviously in children and adolescents, we talk about how far they are from the 95th percentile in order to get the BMI. The ASMBS guidelines also say that adolescents with cognitive disabilities or with a history of treated mental illness or eating disorders, immature bone growth, or a low tenor state should not be denied treatment. So there's a discrepancy there. Now, what about older adults? We know that life expectancy throughout the world has been steadily increasing, but with that steady increase, we're also seeing the proportion of older adults suffering from obesity. We know that our older population also benefits from the effects of bariatric surgery, both in terms of improved comorbidities and improved quality of life. However, we need to remember that they may have a bigger burden of underlying disorders, especially their physiological reserves tend to be decreased, and they may also have poorer tissue healing. So we need to be able to counsel them carefully about the somewhat increased risks, especially from those underlying diseases, and the possibility of less satisfactory outcomes in terms of weight loss. So they anyway would get good weight loss, but sometimes we see that as they are less active, they will have less weight loss than their sort of adult counterparts, their younger adult counterparts. Now, we also need to remember that for the lower BMI patients suffering from obesity, we have other options, including the endoscopic options, intragastric balloon, sometimes aspiration therapy. Now, we've talked about the indications for surgery. Now we talk about the absolute contraindications. If a patient is unfit for a GA, speak to your anesthetist if you have borderline patients, because they may help in ameliorating them to get them to surgery, but they will need more support in terms of possibly a high dependency bed. So that's one. And the other contraindication would be psychological problems like acute psychosis, patients who have had recent suicidal attempts, or active substance or alcohol abuse. In terms of contraindications for specific operations, sleeve gastrectomy, one contraindication is Barrett's esophagus, and with Roux-en-Y gastric bypass, one anastomosis gastric bypass. Certainly, if they have dense abdominal adhesions, you need to be wary and counsel them. And with smoking, certainly any operation that involves a joint and anastomosis, be careful with smoking. Get them to commit to stopping smoking, not just stopping for the operation, but to commit to stopping smoking long term because of anastomotic problems, bleeding, perforation, stenosis. Now, regarding the choice of operation, so the patient is the key. He or she are going to choose what they want. But as surgeons, we need to understand their motivation, what they want, what they want to, why they want it. Yeah, so we need to be quite cautious to understand whether they've got realistic expectations. Say if someone with a 30-year history of type 2 diabetes, you know, coming for asking for a remission, you know, we need to be realistic in what we can offer with which operation. We need to understand what surgery they've had before, especially abdominal surgery, and what future surgery or treatment they're wanting. Things like if we're doing it as a bridge to transplantation, if we're doing it as in patients who suffer from primary infertility and PCOS, as a bridge to them having IVF, we need to be realistic and speak to them preoperatively about things like waiting for weight stability before conceiving. We need to understand their medical problems and ameliorate them. We need to understand their compliance, you know, whether they will be able to have long-term mineral and vitamin supplements, whether they can stick to a healthy diet post-op. But most of all, you know, how will surgery affect their job? So, for example, if you have patients that are drivers and do not have access to bathrooms very easily, you know, I get some patients that tell me, you know, I couldn't tolerate Zeneca, you know, that's a lipase inhibitor, because I had to stay running to the bathroom, which I don't have in my place of work, or, you know, I have limited access to. So we really need to understand their jobs and their social circumstances, and sometimes even their financial circumstances, whether they can actually afford to get the vitamins and the supplements that they might need. And we've already talked about smoking. So the surgeon needs to provide information about all the options, including the do-nothing option, with its consequences, with its effects on health, but also on other things like endoscopic options, the different sorts of surgery. And we need to do it in a way that the patients understand it. Whenever I say to a patient, oh, you might get dumping, what are they understanding by that? The surgeon and the team also need to understand their skills, whether they are really have got the technical skills to do the operation that the patient is asking for, and whether they can support the patient after operations like that. So to summarize, we talked a little bit about the indications, about BMI, and about the effects of weight on patients. Do these guidelines need to be revised? The NIH are 30 years old. I know that the NICE guidelines are currently being revised. And always remember that because there's a guideline, it doesn't mean that it has trickled down to your referrers. So, you know, always try to disseminate this knowledge. Yeah. So thank you all very much. I look forward to your questions.
Thank you very much, Cynthia. Thank you for that lovely presentation. I hope I can be heard.
Yeah.
So that was Dr. Cynthia Borg, our consultant and upper GI and bariatric surgeon at the University Hospital Lewisham in London, speaking to us indications and choices of operations for obesity surgery. Cynthia, thoroughly enjoyed that lovely presentation. Cynthia, what's your take on using scoring systems like the Edmonton scoring system to design algorithms that may help us not only choose patients, but also advise on the kind of surgery that we may potentially be able to make it easy for the patient in terms of understanding?
I think thank you for the question. I think they do have a role, because obviously we need to make sure we've got different options, and obviously we are the experts. The patients are, you know, the people actually having the operation, but we are the experts, and usually most patients are, do listen to our guidelines. So as we were saying before, usually we would try with things like they would all have tried with diets, and there are people, it's a chronic disease. There are people that do very well with medical therapy. There are people who do very well with endoscopic therapy, but we need guidance as to what, especially in, say, a healthcare system like in the UK, where you're actually have got not only you need to get the best value for your money. Certainly in our practice, we use a combination of it. I mean, I sometimes am very reticent to say, if I have a patient with a BMI of 34.5 but diabetic, the guidelines, strictly speaking, say, don't offer surgery, or with hypertension, especially with diabetes, we're okay, but with hypertension, don't offer surgery. But then what will the patient do? If the patient will just gain some more weight to be eligible, so that's not good for anyone. That's not good for the surgeon. That's not good for the patient. That's not good for society. So I think we do need a combination, and maybe we're going to see that reflected in future guidance.
Thank you. One last question before I open it to the rest of the members. What's your take on revisional surgery? Do you think the community at large needs more guidelines in terms to regulate these kind of operations? It seems after a while, every surgeon starts going on to revision surgeries, and we're kind of lacking in terms of guidelines for these.
Again, it's a chronic disease. I mean, if you get cancer of the breast and then get a recurrence, you're not going to stop, doing the second operation for a patient, or if you need stage surgery for, so why are we? I mean, yes, I think there needs to be some regulation as to who does it, or what skills or what volume you need. But I don't think that that we should be biased against our patients who need further surgery. We don't understand why some patients get a good result and some don't. So I think there needs to, first of all, be less bias, but also more science and more, about this, because certainly there is not a one-size-fits-all operation. We all know that.
Thank you, Cynthia. Thank you. That was really nice. It's my honor to open the session to the floor. If there are any questions from the other members, please feel free to ask.
Cynthia, in the UK, what percentage of your patients come to you directly as a surgeon versus the percentage that are referred to you by primary care physicians or other physicians?
So on the NHS, all have to be referred by their general practitioner or by a consultant colleague, say an endocrinologist or a respiratory physician. The patient will not be able to just say, "Oh, I want to see Ms. Borg in the National Health." They can. There are some instances where they can do that in the private sector. Insurance, unfortunately, most of the insurances in the UK do not pay just for straightforward bariatric surgery. We may do some in the context of reflux, or in some people that have sort of international insurances, but not the standard UK box standard health insurance. So most would need a referral if they are coming on the NHS.
So with your system there, much better than we have in the States, the primary care doctors do accept obesity as a metabolic, as a disease, and are therefore willing to refer the patients.
There is more and more awareness, and Professor Fobi, about this. I mean, we've had some very, very good GPs that have themselves or their relatives maybe have had bariatric surgery and have been championing the cause, both on social media, but also most importantly, so in GP fora with our other GP colleagues. So there has been exceptional work. We have also very, very some very good patient groups that actually champion the cause and, you know, are very vocal to teach other patients and to sometimes even take it into their to their GPs. So the GPs can go to the the patients can go to the GPs and actually say, listen, I fulfill all the guidelines, I want a referral. So that is acceptable, but they can't come to me directly to my office and pop a letter and I'll see them, for example.
That's interesting. Scott, do you want to weigh in on that as it relates to us in the States? You're muted. All right. I think Dr. Scott.
Can I just ask?
I'm here, I'm sorry.
Yeah, go ahead.
Well, you know, as you know, we're still following the 1991 guidelines, and all of the guidelines beyond that are only modifications of that guideline. It's not really a change. And as you know, BMI is an awful marker for adiposity. So what we're doing is we're rewarding the BMI of 41 and we're hurting the BMI of 39, even though they may be identical patients. As you may or may not know, IFSO is planning to redo the guidelines, and hopefully we can come up with guidelines that are more reflective of patient disease and patient benefit and quality of life than it would be what a BMI unit is.
Good. All right. If there's no other question, we'll move on to the next speaker. Dr. Kermansaravi? Kermansaravi. Are you on board?
Greeting from Tehran.
Good.
Greeting from Tehran. I am proud to invite Professor Scott Shikora as the next keynote speaker for presenting his lecture as optimization of patients for bariatric surgery.
Cool.
I'm Dr. Scott Shikora, and I'd like to talk to you today on optimization of patients for bariatric surgery. Here are my disclosures. None of them have any bearing on this presentation. As we all know, bariatric surgical candidates can be medically and behaviorally very complicated. Good results require that these candidates for surgery be optimized, that they undergo a comprehensive evaluation and preparation. This presentation will go over some of the steps. Well, first of all, patient selection. There's a hard absolute cutoff at body mass index of 35, which was based on a consensus conference in 1991, 30 years ago, by the United States National Institutes of Health. And unfortunately, this is still being used today. Additionally, patients need to undergo a behavioral evaluation, a dietary evaluation, a surgical evaluation, and a medical evaluation. As far as mental health, a significant number of patients coming for bariatric surgery will have pre-existing health issues that need to be addressed prior to surgery. As far as dietary evaluation, these patients come to us, they need first to be educated on proper nutrition, as many of them do not know what a calorie is, what's the difference between the protein and carbohydrates. And they also need to be educated about what the diet is going to be like and the mindful eating that they'll have to do after surgery. The dietitian actually wears many hats. They also will help assess the patient's preoperative nutritional status and correct nutritional deficiencies prior to undergoing surgery. Additionally, for those patients who require preoperative weight loss or require assistance with postoperative weight loss, that falls into the dietitian's responsibilities as well. And because the dietitian interacts with the patient as often as they do, they have the greatest relationships with the patients, more than the surgeon or the other providers will likely have. This is data from our own institution, which just demonstrates that patients often come deficient or borderline deficient of several nutritional parameters such as ceruloplasmin, copper, vitamin A, vitamin K, and zinc. So these need to be corrected prior to surgery because surgery can actually exacerbate these conditions. Every program will have its protocol of what blood work to check. This is what we check at Brigham and Women's Hospital, looking at the vitamins, looking at the hemoglobin A1C, the PTH, the liver function tests, etc. What about the medical health status? Well, as we know, the majority of these candidates do come with comorbid conditions, and the higher the BMI, the more likely that they'll have these conditions. It's important for the team to, first of all, understand which conditions the patients have, and are they being appropriately managed for those conditions? Are they on the right medications, et cetera? Additionally, it's our responsibility to look for some of the undiagnosed conditions the patients may also have, such as sleep apnea, that their primary care physician had not ever checked for. It's important for us to do so and to manage it accordingly. There are several apps now available, including the one from the ASMBS that can help you risk stratify your patients to determine who's the high-risk patient versus the patient whose risk may be somewhat less. And also to have a low threshold to obtain the appropriate consults, whether it's hematology, cardiology, et cetera, to help get the patient in their best shape prior to surgery. Now, I've always told my students and trainees that obesity adversely affects every organ system of the body, and that's absolutely true. So this is what we're going to see when the patient comes into the office, and these are the conditions we need to manage prior to going to the operating room. As far as preventive testing, we've already talked about blood work, but also includes x-rays, upper GI studies looking at the upper anatomy of the GI tract, chest x-rays, et cetera, for patients who may have a smoking history or previous heart or lung disease. And there's question marks next to endoscopy and sleep studies because of the controversy of whether they should be mandatory for all patients or selective. We already talked about consultations, and just understand that the protocol of your program may be different from one patient to the next or from one center to the other, even in the same locale. As far as cardiac consults, I don't believe that a 30-year-old perfectly healthy BMI 40 patient requires a full cardiac evaluation, but certainly the patient over 50, the patient who has a history of smoking, high body mass index, history of heart disease or chest pain, suffering from metabolic syndrome, those are all risk factors that should at least warrant a consideration of a cardiac consult. Sleep apnea. Approximately 80% of bariatric surgical candidates will have sleep apnea when tested. And as you can see for men, it's almost 50%. What's interesting in the study by DRAF, while 60% of patients had sleep apnea on sleep study, almost half of them had what was termed as moderate, severe, or severe. And those conditions will require treatment with either CPAP or BiPAP that should be started a few weeks before surgery because it takes a while for the patient to get adjusted to wearing the mask before they go to bed. What do you do with the patient with mild to moderate sleep apnea is a bit controversial. In many cases, they don't need to undergo the use of a CPAP or BiPAP machine and might be able to just undergo surgery, and then the condition should improve with weight loss. Preoperative endoscopy is something that some people feel should be mandatory to visualize the upper foregut for all patients prior to surgery, and others who feel that it's too much cost and for many patients will come up negative, and they're more inclined to do a selective approach to study those patients that have risk factors. In this study, they looked at all comers for approximately 500 patients that were already cleared for bypass or sleeve. And as you can see, while 49% of patients had normal studies, 51% had some type of a finding, but overwhelmingly, the abnormalities were either without consequence or easily managed by placing the patient on PPIs, such as mild gastritis or esophagitis. Only one patient was found to have significant Barrett's esophagitis with carcinoma, and only 1% of patients had their surgery postponed because of findings at the time of the endoscopy. And the authors estimated that it would cost about $300,000 on endoscopies to find one lesion that would postpone surgery. However, having said that, still many people believe in the selective approach and to only endoscope those patients that are high risk, such as those that have family history of cancer or polyps, those that have strong histories of symptoms such as heartburn, abdominal pain, vomiting, those that have had previous disease such as ulcers, and those that are going to have revisional bariatric surgery. What about surgical considerations? It's important for the surgeon to investigate all previous abdominal surgeries that the patient had, first by history and physical, and asking them, what's this scar from on your belly? What's that scar? Patients may or may not remember what surgery they had, depending on how long ago it was, and if possible, obtain the operative reports. In addition, I would suggest strong consideration to upper GI studies and even endoscopy for all the patients coming who have had previous GI surgery, particularly GI surgery of the upper GI tract, the foregut. Don't go into the operating room unprepared. Now, there are some procedures that would then change what your approach is going to be to the patient from a metabolic standpoint. For instance, if the patient had a history of Crohn's disease or significant small bowel resection or small bowel radiation, that patient may have a contraindication to a gastric bypass or another anastomotic procedure like a duodenal switch. As sleeve gastrectomy may be contraindicated in patients with significant GERD or significant Barrett's esophagitis. So that may play a role in what you can and can't do for the patient. Preoperative weight loss, also controversy whether it's selective or mandatory. We do know, and there's no dispute, that a modest amount of weight loss will improve a number of the conditions the patient brings to the table, from glucose control, sleep apnea, blood pressure management, asthma, pro-inflammatory and probiotic states, heart and lung function. We know they'll all get better, but the point that is raised at meetings is how much weight loss, what if the patient can't lose weight, how long do you give them, and is it ethical to postpone their operation for the sake of preoperative weight loss? Now, this is CAT scan cuts of the same patient. We're at 95 kilos, and then after a 10 kilo loss at 85 kilos. And as you can see, the girth is dramatically less after weight loss. And all of the white that you see, that's fat. And as you could see in the patient on the left, there's so much more abdominal fat that the surgeon is going to have to deal with, in addition to a big fatty liver. There is data, although not great data, from a lot of retrospective studies that preoperative weight loss may also reduce operative time, reduce perioperative complications, and may improve weight loss, both short-term and long-term. So what do I do prior to surgery? And I added some adaptation from Dr. Christopher Still. 1 month prior to surgery, for those who need to lose weight, we may start pushing them for preoperative weight loss. 2 weeks prior to surgery, we put all of our patients on a modified liquid diet that we tell them is a liver shrinking diet, so they understand why we're doing it. 1 week prior to surgery, we stop medications such as NSAIDs, aspirin, antiplatelet medications. 48 hours before surgery, we'll stop other medications such as the SGLT2 inhibitors, the diuretics, metformin, and other medications that can be held prior to surgery. What have we accomplished with optimizing patients? Well, if you look at the MBS-equipped data, we dramatically reduce complications to almost unbelievably low incidences and mortality rates below 1%. And if you just go back in time to 2002, which you could see on the graph on the left side, on the right side of the slide, the mortality rate in 2002 was about 4%, and it's dropped all the way down in a short period of time, 2009, to less than 1%. And that's quite an accomplishment in the field when we're operating on very complex patients. So in conclusion, bariatric surgery candidates are high risk for surgery. Proper preoperative evaluation by a skilled, experienced multidisciplinary team and patient optimization are necessary to reduce complications and should improve overall outcome. I want to thank Drs. Fobi and Bhandari for inviting me to participate in this conference, and thank you very much.
Dr. Kermansaravi.
Thank you, dear Professor Shikora. I have some questions. What is your idea about the patients with endometriosis? As we know, endometriosis is a chronic disease and may have recurrence after surgery that may need a small bowel resection or colonic resection. Do you think endometriosis can be a relative contraindication for gastric bypass or not?
I could see it both ways. I don't think it should be an absolute contraindication, but in a patient with extensive endometriosis, you do have other options such as a sleeve. I think if you're looking for a illness, an abdominal illness that should be an absolute contraindication to a gastric bypass, that would be the patient with Crohn's disease. But I don't think endometriosis by itself should be an absolute contraindication.
Thank you. Dear Professor, how many weeks before the bariatric surgery do you recommend quitting smoking?
That also is controversial because the adverse effects of smoking as they relate to going to the operating room and being intubated can be several months prior to the operation. But I think in most programs, they probably would accept anywhere from 2 to 6 months of being smoke-free.
Do you think the pre-op evaluation in patients with BMI more than 50 may differ from the patients with BMI less than 50?
I'm sorry, you think you were asking if the workup is different for over 50 versus? Yeah, I would agree. I think you are more likely to get a cardiac consult. You're more likely to be dealing with more severe comorbid conditions when the BMI is over 50 versus under 50. You're likely dealing with a more difficult operation because of the abdominal adiposity. So yeah, I tend to get more consults. I rely more on preoperative weight loss in that group of patients.
And the last question, do you recommend H. pylori eradication in all patients with H. pylori positive prior to surgery, also all bariatric surgeries, even a sleeve gastrectomy?
I'm sorry, you're asking about endoscopy?
No.
Okay.
No, I'm sorry, I didn't hear you very well.
Eradication of H. pylori.
Oh, you know, that's controversial. There's articles in the literature to suggest they reduce marginal ulcers and other articles in the literature that claim there is absolutely no effect of H. pylori. And where I work, some insurance companies mandated it and other insurance companies didn't care. So we tested it for patients that it was mandated, and we didn't always test for patients where it wasn't mandated if they were asymptomatic.
Thank you so much.
Thank you.
Okay. Any other faculty member has questions for Scott? Okay, Mohit.
Okay, so now I think I would invite Prashant Salvi to deliver his lecture. I've already introduced Prashant. Prashant, can you start?
This invitation.
Prashant is going to speak upon makeup and protocols
of pediatric surgery program. I have no conflict of interest, and these are my case-mate disclosures. I do 50% of sleeve gastrectomy, 33% of NGBs, and 17% of through and by gastric bypasses. So as we all know that obesity is an alarming epidemic, and there are enormous implications for our healthcare system. these obese patients require more healthcare than average people, and there are increased physical problems, not just only to the patient, but also to the staff and administrating that care. Respecting patients' dignity and delivering optimum care should be the primary aim, but also we should be focusing upon establishing procedures for safeguarding the health and well-being of these patients and the caregivers. Now, when we talk about a bariatric surgery center, there are various components which are involved, and as we go ahead in this talk, we will be covering these points in brief. So we start with the database. A well-maintained database will always demonstrate the past performances and help us direct future trends. So we should also know that which surgery is giving us good benefits at the end of 5 years, at the end of 10 years. So we can direct our future trends according to the experiences what we got or the results we get. So when we talk about an MBS committee, there should be an MBS director. The surgeons who are involved in the team should all be performing bariatric and metabolic surgeries. There should be an MBS coordinator, there should be an MBS clinical reviewer, also institutional administrative representatives. Now, as we move ahead, when we talk about the surgeon's training, it is a very vital thing in delivering high quality care and in a consistent manner. Each center must have at least one verified surgeon who is performing bariatric and metabolic surgeries. Now, when we talk about verified surgeon, it's a surgeon who has a lifetime procedure volume of over at least 100 stapling procedures and a volume of at least 25 stapling procedures annually. These verified surgeons should also document 24 hours of bariatric specific CMEs, and that should be every 3-year cycle. So the committee should also have designated persons such as a registered nurse, a pediatric physician, dietitian, psychologist, psychiatrist, social workers, and physical and exercise therapists. So the registered dietitian, they are an essential part of the success of any bariatric center. Daily nutritional counseling, pre and post bariatric surgery is very essential component of any bariatric center for any success of a bariatric center. These dietitians are in an ideal position because the patient's eligibility as well as the compliance from a cognitive and motivational perspective. Appropriate care and access should be there to have a nutritional counselor's numbers with the patient, and periodic lab assessment of nutritional parameters is also important to avoid complications of vitamin deficiencies. So these obese patients always carry a diagnosis of depression, anxiety, and other stress-related conditions. They also have problems with body image and have a low and demoralized self-esteem. So where this psychologist play, they have an invaluable support in assessing the patient's mental conditions and the counsel patients to withstand the lifelong changes imposed by bariatric surgeries. So when we talk about a bariatric design, all important things should be considered, like the appropriate facilities, the space, the furnishing. Everything is important when you design a particular bariatric center. And it doesn't start with the patient sitting in front of you in the OPD, but it starts as soon as the patient starts entering into the hospital. Because these patients, they are wheelchair bound and they are on walkers. So there should be adequate handrails and bars to accommodate these bariatric wheelchairs and walkers. Also, there should be quite amount of space because these patients require multiple consultations from the pulmonary point of view, the cardiac point of view. So there should be an access which is comfortable for the big wheelchair to move around in the hospital. When we talk about the patient room, the bariatric room design advisory board have suggested the width of 14 feet and the depth of 15 feet. Their beds, which they say should also be of good quality and comfort, should be given to the patient, and also they should withstand this heavy weight of the bariatric or the superly obese patients. The room should be quite big enough to include both the bariatric patient as well as the caregivers. The curtains should be ceiling mounted, and if possible, the bariatric facility should have a dedicated metabolic and a bariatric surgery floor. And what more important is, these patients require a lot of assistance, even while getting up from the chair or going to the toilet. So at least 2 or 3 caregivers might be required for one single bariatric surgery patient. And when we talk about the bathroom, the bariatric room advisory board prefers a pair of unequal leaf swinging doors, and sliding doors are also preferred with an overlapping overall opening of between 9 to 12 feet. The toilet seat should be also oversized The toilet fixtures and sinks should be mounted to the floor and should not interfere with the wheelchairs. So as you see in this picture, there are multiple grab bars. So the patient has an easy access while getting up and while getting down from the wheelchair, and should be quite big enough to accommodate the patient as well as the caregivers. These patients, when they are in the lobby or in the waiting area, they are always very skeptical and scared to sit on the furniture on the chair because they might break. This is what they feel. So when you design the lobby and the waiting area, the seat, the width should be big enough and should be quite roomy so that these patients can comfortably sit in the waiting areas on the lobbies. The wheelchairs, the stand chairs with arms are a particular problem in this case because they cannot fit because some patients are pear shaped, some patients are apple shaped. So these all things should be taken into consideration. The operating room especially should be outfitted to safely hold and secure a bariatric patient. When we talk about the OT table, the capacity should be at least, the whole capacity I'm talking about should be at least 1,000 pounds with a tilt capacity of 600 pounds. And the table should also have side extenders, foot boards. They should have foam padding available for the arms, heels, and feet. Obviously, these patients are big, so the instruments, the length of the instruments also should be bigger, like the long suction catheters, the scopes also are bigger size required, and also the adequate oversize is also an important aspect. Field of vision is always an important aspect, not just for bariatric surgery, for any other surgeries as well. So good vision is mandatory, and 4K and 3D monitors do a very commendable job in this case. ICU, when you talk about the critical support, ICU should be well equipped to handle bariatric surgery patients because this patient might require unexpected critical care. So an on-site ability of a person capable of administering advanced cardiac life support is very important. Anesthesia and bariatric surgeries. Now, anesthesia is a very important aspect in bariatric surgeries because these patients are really huge, and the anesthesiologist plus the anesthesia assistant, everybody should be experienced in diagnosing and treating imminent life-threatening conditions such as the difficult airway, hypoventilation syndrome, apnea, congestive heart failure, renal insufficiency, and venous thromboembolism. At times, the anesthetist might give you a clue that the patient is not optimized preoperatively and could be optimized well after maybe giving some BiPAP or some sort of preoperative optimization. So their suggestions also should be taken seriously because at the end it is the aftercare which is more important than the coming out of anesthesia or the coming out of the ventilator is more important for these bariatric surgery patients. And when we talk about educational workshop, they are very beneficial exercise between the prospective patients and the caregivers because these patients need to know the exact pathway they will be following during the surgery, the risk and the complications of the surgery, the diet and the exercise guidelines. So this all involves in a proper educational preoperative workshop to all the prospective bariatric patients. Support groups, these are important aspects when you design a surgery center because they should be targeted for patients in the recovery phase of operations and should be majorly concerned about medical, nutritional, psychological, and social issues. Additional gain may be achieved by holding informal educational lectures for these patients in the form of support groups. So, as we all know, there are multiple bariatrics and surgeries which are right now available, like the sleeve bypasses, mini gastric bypasses, endoscopic procedures, the PPDDS, single anastomosis, duodenal ileostomy, plication, gastric balloons, ileal interposition. What is algorithm now? When Dr. Fobi and Dr. Mohit Bhandari, they had designed this algorithm and which is very useful. So based on that algorithm, sleeve gastrectomy can be advised to a young patient who is less than 50, has a history of smoking, is non-diabetic, has no hiatal hernia or GRD, has mid-abdominal LFTs, NASH, and mild cirrhosis, has peptic ulcer diseases, has got multiple small bowel surgeries, and super obese or the high risk and where anesthesia time need to be less. So in all of these cases, a sleeve gastrectomy can be advised. Like same way, a gastric bypass can be advised to an individual who is diabetic and has an HbA1c of less than 8 and a duration of less than 5 years. for hiatal hernia and GERD, gastric bypass is still a gold standard and should be offered to all the patients with hiatal hernia. Has a BMI of less than 50, are vegetarian, have history of alcohol intake, have some degree of NASH at the time of surgery, and who might not be compliant with the follow-up. Now, for MGB or OHGB, the algorithm says that these surgeries can be offered to diabetic patients who have an HbA1c of greater than 8 and the duration of more than 5 years are on insulin, have poor dentition, have no GERD, are non-vegetarian strictly, and have a BMI of more than equals to 50, most likely to return to follow-up. So these patients, a close follow-up is always very important, and who do not have alcohol intake, they have normal LFT, and they have no NASH at the time of surgery. So I still follow this algorithm at my center, and I'm really benefiting over this algorithm, and would urge all to go through the algorithm and follow the same at your centers, respective centers. These are few references for my talk, and thank you for your all patient listening. Thank you.
Okay, I think Dr. Bhandari is gone over to the surgical suite.
I'm very much here.
Oh, you're here? Okay, go ahead.
Yeah. So, Prashant, congratulations for a great lecture. See, you have, I'm so proud that you have trained with us and you're doing a great job now. I have a question for you. So now you have started your own bariatric practice, and I hope you will also have fellows under you. So, we talked about an ideal bariatric surgery center of excellence where, you have so many requirements. But suppose somebody has to start his own setup where he cannot invest so much. What do you think should be a bare minimum requirement for a surgeon to start working in a unit to do bariatric surgery without involving risk? What should be those bare minimum requirements? If you can just, I know that, the center of excellence will have so many of them, and most of them would be necessary, but what according to you is that bare minimum thing which surgeon should have in a setup to start bariatric surgery?
So according to me, if you ask, the bare minimum thing is the training. The training is the most important aspect of any bariatric surgery center to work. Like for in my case, I was at your center, which is the highest volume center. And I've actually seen so many number of cases and I've seen so many other aspects of revision surgeries and has actually taught me a lot. So the practical aspect I feel is the most important aspect of starting for any center or any center to have a successful rate or a successful outcome. The training is the most important aspect. See, instruments, the monitors and everything can be achieved at a later date, but until and unless you have a proficient training, there's nothing matters in as compared to the training what you have. So if you ask me, probably sir, the training is most important. That is the only important aspect I feel.
Okay. And my second question to you would be, I know probably Scott can tell you more about it, or maybe Alaa can tell you, but there are specific privileges in hospital to endoscopy or not. Do you really think that bariatric endoscopy should be an essential part of surgical training for bariatric surgery?
100% sure, sir. 100%. It is actually an important aspect. Preoperative endoscopy is an important thing. What I learned at Mohawk, I still follow the same. So I do intraoperative endoscopy of all my patients. When I started a bariatric center here, the first mandatory thing which I told them that I would like to have an endoscope in the OT. What I saw and what I presumably feel that these patients to give anesthesia twice is again a big risk. So if you do the endoscopy in the OT itself, it gives an added advantage. The patient is also at ease, and you can do the endoscopy at that time. The patient is not, he's not forwarded for 2 times anesthesia. Plus, it is very convenient for the surgeon also to do the intraoperative endoscopy. So I feel it is mandatory, and what papers we have published, it says that there is a good amount of literature supporting that intraoperative endoscopy is mandatory, and I think it should be the protocol forward also.
Okay, thank you. We will now move to the OR. I'll be starting with a case, but in the meantime, Shashank can present the case.
Thank you so much, sir.
Thank you. Okay.
Good evening, everyone. Welcome to Moho Goa. Today we have a 39-year-old male with a height of 177 centimeter and a weight of 132 kg with a BMI of 42.1. He is non-vegetarian by diet, has no addictions. His osteoarthritis with intermittent symptoms, obstructive sleep apnea, and type 2 diabetes as comorbidities. He has a good level of serum albumin, which is 4.4. HbA1c is of 7.0. He has been tested for all the viral markers, including COVID-19, and has been tested negative for them. And the USG showed grade 1 fatty hepatomegaly.
If any of the faculty members have any comment or any questions they can ask while Dr. Bhandari is getting ready for surgery.
Yes, can they just talk us through what they're doing different now with COVID? Are they asking their patients to shield beforehand? We did see that the COVID test is negative. How soon before the operation are they doing that? Thanks.
Okay, so can you hear me?
Yeah.
Oh, no, thank
Okay,
you.
so as far as we are concerned, we are ready with the intraoperative endoscopy. I'll also answer Cynthia's question. Just let me complete this endoscopy. So if you can see, we are inside the esophagus, and this is the Z line. This patient had mild esophagitis, but that's not a very severe form of esophagitis. So what basically we do is first we look for any sort of lesion or any esophagitis if we have, and then what we look for is a normal duodenum, because we would be bypassing this area. And when we pull the scope out, we can see that the duodenum is perfectly fine. There is no tumor or polyp or lesion here. Once we go back, we also look for a hiatus. Although I also believe that most of these hiatus are visualized in a much better way when we look them while doing a laparoscopy. So here we find that the G junction is at the normal position. We are not seeing any hiatus or any other abnormality inside the stomach. The Z line, apart from what I already said, mild esophagitis, I don't find anything significant here. And this patient looks to be a fit case for gastric bypass. Now, as far as what Cynthia's question was, so we admit all these patients into the hospital, and once they are admitted, they are not permitted to leave their room, and most of the investigations which are done would be done. So once the patient is turned out to be COVID negative, he's not supposed to leave the room. So this answers your question, and we immediately operate upon the patient. The maximum time duration between doing this surgery and getting a negative test would be around 12 hours, I would say. Sometimes if we have some doubt, we also do a chest CT to rule out if there is a lesion. So that answers your question. Now, just for the sake of paucity of time, we've mobilized this omentum here. And I'll just first explain the port position. So if you can see, this is my optical port, which is supraumbilical. I have two 12 mm ports, both on the side of the optical port in the anterior axillary line. And then I have two 5 mm ports, 2 finger breadth below the subcostal margins in the anterior axillary line. So I'm working with total 5 ports. We have put in a Nathanson's. The first thing is we observe the G junction so that we are sure that we'll be able to do the procedure. The second step would be to basically divide this omentum, which I already did just to save some time. And now we will first do the jejunostomy. So this is the ligament of Trides. That's the inferior mesenteric vein. We usually keep the limb lengths to a standard of around 80 centimeters as a BP limb and 100 centimeters as the elementary limb. So this is my grasper where I count 10, and this is around 80 centimeters here as the BP limb. We divide the BP limb using a white reload. And once we have fired the load, we mobilize this mesentery a little bit because we are going to take the rule loop up. So the rule loop or the rule limb should not have tension while we do the anastomosis. The pouch is around 5 to 8 centimeters, which means that we're going to go very close, high up towards the anastomosis. So we want to make it sure that we absolutely have no tension over the rule loop. So that's our BP limb, which I'm going to mark with a clip so that I'm not confused. And my rule limb or my elementary limb is here. So we again going to count around 100. So that's 10, 20, 30, 40, 50, 60, 70, 80, 90, that's 100. So this would prevent the bile reflux into the gastric pouch. And then this is the elementary limb, and that's the BP limb, which I marked with the clip. I would make a enterotomy here, and the trick here is to make the enterotomy a little closer to the anti-mesenteric border, so that we have good amount of tissue of the bowel lying in front of us while we're doing the enterostomy. And that's the clip, so that's the BP limb. So this is the clip here, and that's the BP limb. And now I'll make a sort of a small enterotomy here. So this is, this should be sufficient enough just to make sure that we do not sort of make very large enterotomies, because I can then close it with a suture or with a staple, whatever I want. I usually use staplers to close the enterotomy, but the trick here is to make a small enterotomy, not a very large one. So, if you have proper assistance there, even this small enterotomy is good enough to accommodate the blade of the cartridge. So that's it. We can now, take a complete 6, fire the white load. And then once we have fired this white load, we can again go in with a stapler and close the enterotomy with a stapler. We can do the same with a suture technique. I use a staple most times, but when we have fellows, we give them a chance to suture this by using even a Vicryl or something, whatever they want to. Now this is the way to do it stapled is very simple. You rotate this loop, hold one end by using a grasper and the other by using a Merrill end forceps. And what we principally do is just come in. So this is what we have to hold here, and then stretch it a little bit, and then we come in with a white cartridge. Now when I lock it, I make sure that I see both the ends. So you can see the 3 loops lying here, and plus something which is very easily visualized. So this is closed. I'm not obstructing the lumen, as you can see. My lumen looks nice. Now we'll take a Brolin stitch, which is an anti-obstruction stitch, so that we make sure that all the loops lie. So this is my common channel here. That's my BP limb, and this is my elementary limb. So just for the sake of audience, I'm going to follow the elementary limb. So this is the elementary limb here. Let me follow it down. So you see this goes up there, and here, 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 and then it goes up. So that's the elementary limb, which is going to be anastomosed to the gastric pouch. This is the BP limb, which comes from the ligament, and that's the common channel. Now we will take an anti-obstruction stitch. So this is just joining the common channel with the BP limb, because we don't want this to be twisted. And I do this step, like I've been doing this to standardize my gastric bypass, and we have fellows doing it at our center, because then this is a standard way of creating an anti-obstruction mechanism so that we never have a problem here. So that's it. Now, the other advantage of using this stitch is that anybody wants to retract it, for me to close the internal hernia defect can do it. So you can have one of your assistants to retract it. So we can use a 5 mm port on the left side to retract this particular thing by using this. So just hold it with a Merrill end and hold it up. Now, what is the benefit? So you see this beautiful internal hernia defect, and this can happen. So we're not going to leave it like that. So now I'm going to close this internal hernia defect. So the first suture from the bottom will always be a purse string. And here I make sure that I, take the base as cleanly as possible, because if we have the base nicely laid down there, then we do not leave any chance of an internal hernia. So this is the benefit here is good exposure. So you can see that when I used my assistant on the left side to hold that for me, I'm getting very good exposure of the defect. At most times I've seen surgeons getting exposure of this particular defect. So you can see the defect is very nicely laid down. And now I can start to, suture it towards the assistant where he's holding it. So I can go up towards the cephaloid end, and I'm not going to take, very deep bites, but just the bites to make sure that I get good adhesions here, so that in future I can avoid any chance of having an internal hernia through this mesenteric space. So just trying to make closure. Another good point here is that we can use different kind of sutures. Here we are using an ethibond to close it, but we can use proline, we can use silk, any sort of a non-absorbable suture. I have used quill, a non-absorbable quill suture here, and that also work. I haven't used V-lock here, but all these sutures I have used. We have used Stratafix before when we were doing a lot of robotics. These days we do less of robotics, so we don't use that suture, but all these sutures work pretty well here. The technique remains the same. The assistant is holding it, and then I can get a very good view of the common channel here. So I just sort of go close and just turn my bowel, so you can see I can see the BP limb there. So this is my BP limb, that's my common channel going there, and I know that I have not obstructed this lumen. The assembly looks very clean to me in the entire procedure, because I'm concerned about the anastomosis at this end. If we have a twist, or we have the most common causes of chronic abdominal pain, or maybe an obstruction in a gastric bypass. So once we follow these steps of making a very clear common channel and this closure as a step, as a protocol, these problems do not happen. So that's my internal hernia. I'll again demonstrate that, so you can see that's the internal hernia closure. And now I can go up, make the pouch, put in a band, and do the gastrojejunostomy. So at this point, I would want my anesthetist to give patient a little bit of supine. We just gonna go a little head up, pardon me, and then just this loop is gonna be above the transverse colon, just kept there. I use the pars flexida technique. I'm not going to go into the debate of whether to use pars flexida or perigastric. We have done more than 5,000 gastric bypasses and used the pars flexida all around. And we never had a problem with this partial vagotomy in draining of the pouch, because we all know that in gastric bypass, we already bypassed the pylorus. So that pouch drains pretty well, even though we have some vagotomy here because of doing a pars flexida. But this is easy for the fellows to follow, because they can go inside, easily dissect this stomach. It's more easier to do a pars flexida than to do a perigastric. I feel specifically for surgeons who are starting. And initially, we did perigastric, but then when we realized that it's good results with pars flexida, it's easier for consultants and fellows to follow, we shifted to this technique. And sometimes we do encounter some vessels here. That's why we need a vessel sealer. So just a sealing of the gastric veins can help us not having problem in future. So because of a lot of fat, we have thick gastric veins here in this area, and that's something which we need to remember when we do a pars flexida. So you can see the posterior wall of the stomach beautifully visualized. Okay, can I have a cartridge now? So this 10 mm sealer, sometimes when we have a bleeding, is better than the harmonic at this area when there's a thick pad of fat which is in the perigastric area. And if it bleeds, it can be easily controlled. So now we will do the first firing. The first firing will be done by a blue reload. which can be fired. I have already cleared the area. And now that is just below the left gastric pedicle. So I'm going to fire here. Below the left gastric pedicle, I am around 1.5 centimeters below the left gastric pedicle. And this leaves me good area or good scope. If there is still some bleeding, I can use a clip here, or maybe a harmonic or a clip, whatever. Both the things work well here. And then I will do a little bit of posterior dissection. So this part of dissection is important. Now, when we dissect this, we can have one of the assistants retracting that part of the remnant. So this can be retracted, and then once this is retracted, we have a very good visualization of the retrogastric area. So this is how we can do. These adhesions have to be removed. Once we have all these adhesions, it makes the job difficult for us, and we cannot go very close. So this is a very basic level of dissection posterior to the gastric pouch, just to make sure that we get the correct anatomy and we are not confused with the fat for the gastric pouch. So this is how I bear the gastric pouch, go close there to the angle of his, and this is the crust there. So I'm just going to leave it there at this stage, and I'll come with my another reload, which is a blue reload. So you saw that I did not do a lot of dissection there. Now I can ask my anesthetist to bring in the bougie. So okay, push. Yes, you're right. Okay, so that's the bougie there. It's at the tip, and I can then fire another load. So this is one of the reasons why I did that retrogastric dissection, was to avoid the redundancy here in the pouch, because once we have the redundancy in the pouch, we tend to make a very, very large pouch. So that's why my intention is always to do some posterior dissection, and that posterior dissection prevents from making a larger pouch. So that's it. Now what I can do is, this is another trick. I can go there with my stapler and just retract that area and use my grasper to go and dissect. So I'm not using a harmonic here now. So I'm just going with my stapler and retracting it, and then I can see that I virtually, if I can see, I can virtually come out without using too much of harmonic there. In case if I require the harmonic, I can go there and do some little bit of dissection, but that is also possible by using a blunt grasper. So you can see this is what I do also in my mini gastric bypasses. We do not use a lot of harmonic there close to the GE junction. So so what basically we do is just bring in the cartridge like I did here, do a very minimal dissection with the grasper, and that's a blunt grasper. So that's something I usually do in a mini gastric bypass. We are scared to damage, at most times we are scared to damage the area close to the G. Can you push the bougie, please? Push the bougie again. Push it, push it, push it. Okay, so now we have the bougie in place. I have a pouch which I would like to band, but before doing that, a little bit of fat dissection here. This is not, one of the cases where there are certain cases where you have very less fat with the pouch. This is not one of them. This is some patient which a little bit of metabolic syndrome, so they have visceral fat akin to the pouch, and that's what we do and dissect, so that we are very clear about the anatomy as to what we are dealing with. So that's it. Now what I'll do is I'll take a ruler scale, I'll measure the length of the pouch for you and the area where we're gonna put the band. So usually, can I have a ruler scale, please? So usually this is the GE junction. So I dissected here. So that's the GE junction, and now you see, keep pushing the bougie, please. So while we measure the length, we ask the anesthetist to keep pushing the bougie. So that's the length is around 6 centimeters. Now what I'll do is I'll place this here, somewhere around 2.5 centimeters. So that's my area to place in a band. Again, little bit of perigastric dissection in the fat by using a grasper here, a Maryland forceps, and then the bougie is in place, and I will try to, can you push the bougie, please? And I'll try to, come across We don't force ourselves till the time we see the grasper, and that's the grasper there. Once I'm pretty sure that I'm through the fat tissue and not through the stomach tissue, I take this grasper out. In this patient, we are using our own self-made silicone ring. With Dr. Fobi, we have been using both the kinds of ring. We use a company made, and if the patients cannot afford, we make our own ring by this silicone material. And that's calibrated to a size 7.5. So that's the same what we get by the companies. This is a silicone, all silicone material, just what the ring is made up of. And I can use a proline suture, and our fellows can make it, and they can use it even in patients who cannot afford to have a ring if it is costly for them, or if the entire cost of the project increases because of the cost of the ring. So the circumference of this ring is around 7.5. We measure it by a ruler scale, and then we make this ring. The advantage of having a ring which is commercial is that it erodes less. According to our data, it's more easily calibrated, because if suppose you go inside and you find that you don't need a size 7.5, you can easily go and, can I have a suction? You can easily go and change. So I'll need a clip here. That's the area. So you can easily go inside and change the ring. For example, if I was using a minimizer ring, I can easily go inside and change that ring and calibrate it. So that's the advantage of a commercial based ring. But if we do not have a commercial based ring, we can use this. But then the only disadvantage is that we are not sure if we need to change it. So we need to keep 2 or 3 sizes ready. Sometimes there is so much of fat with the pouch that the size of the ring needs to be changed. So that in that case, we need to make probably a ring of a larger size. So usually when I calibrate or I make my own rings, I have 2 or 3 sizes available on table so that, I can change the size depending upon the situation, what arises. In this patient, we were lucky. We made a 7.5. And in most cases in gastric bypass, if you remove the fat from the pouch, the size 7.5. So that takes care of the band applied around the pouch. The breadth of this pouch is around 2.5 centimeters. A little bit of oozing at the side can be taken care of by applying some clips. And now we are ready to perform the gastrojejunostomy. So I will again request my anesthetist to push in the bougie. We keep requesting them because we always make these gastrotomies over the pouch, and that makes it very simple. So now, for example, you have the bougie pushed in. I know that that's the location of my bougie. I dissect a very little bit with my Maryland grasper there. So that's my dissection. I come in, make a small gastrotomy, again, not very large because we don't want. So we just see the blue of this bougie and we stop there. So that's the limit of our gastrotomy. Now I can come in with a reload. So that's my blue reload. And we will make another enterotomy here, very small one over the small bowel. So this enterotomy is made around 3.5 centimeters from the loop, which is the end loop. We take a little bit more because we don't want to strain the tip of this particular loop by the cartridge, and that can sometimes cause injury. So I take a little bit more, and because we are using a band, I'm not much concerned about a very small amount of candy cane, maybe 1 centimeter, which remains. So this is my pouch there. I have to make sure that I'm inside the stomach. So the best way is to bring in the bougie again, so we are sure that we have not entered a false plane. So this is my trick. I bring in the bougie. So the bougie is down there. Come back. Okay, so we can now dissect here a little bit if we are not able to bring in the bougie because the patient is not supine. Sometimes you can have a problem in bringing in the bougie, but that there make sure that we are inside by just using this grasper. And now I'm going to make this anastomosis of size around 3 because when I do some suturing, it reduces to 2.5. So that's my anastomosis there. And now we can see that we are inside. I'll use a little bit of gauze here to avoid this bleeding, although this automatically stops. I keep on suturing if I have some bleeding there. It mostly stops by my suturing. So, and usually this bleeding could happen because we have a little bit of fat which was surrounding the pouch. So the fat bleeds, the vessel with the fat bleeds. So I usually would continue to suture and it automatically stops when I start the suturing. Now my way of securing this anastomosis is a little different. So I first take a conal suture at the edge of the anastomosis, just like I did here. And then once we have done, we do a throw of conal suture. So you can see that this is a very small gastrotomy, enterotomy area. And I want to first secure the caudal end here. So what I would do is I would come here outside through this anastomosis here and then go back inside. So this is my corner and I would want this to be perfectly secured. So I go back inside, and when I'm going back inside, the beauty would be that all these bleeding vessels are going to stop because I'm going to take care of the vessels. So we will do an endoscopy post-operatively to make sure because the anesthetist could not push in the bougie. So I will always demonstrate that I was in the right plane when I did my anastomosis. So this is mandatory. So the endoscopy post-operatively is going to demonstrate, although I was sure because I had dissected it with my Maryland forceps, but we always try to make sure that we are in the correct plane. So this is the angle which I'm going to secure. So I take the bite from here, and then we go onto this side, and then this mucosa can be pulled in so that we bury it completely at the corners. So that's the way we secured the caudal end. Now I can cut my suture here. I can actually go continuous, but I'll cut my suture here and I'll again come from the cephaloid end so that we secure the cephaloid corner. So this corner is secured, as you can see. Just clean that for them. So you can see this is perfectly secured, the caudal end, and now I can rotate my bowel and come from the cephaloid end. So that's the advantage when we start to suture, and it's always easier to suture towards you. So you know, I sort of take this benefit of this thing and I just hold the suture at the caudal end and then sort of do the anastomosis. So and here, as you can see, we are using the staple line. So that would also take care of some of the hemostasis issues which were there initially. This patient is a little bit oozy because we gave him preoperative heparin, and that's sometimes there with us. And then this staple line suturing helps us because it does a better hemostasis in lines with blood. And so once I go inside with my scope, most of the bleeding would stop. You can see in the endoscopy when I start that. So that gives the tamponading effect was there with the sutures which I took posteriorly, and then there is a tamponading effect with the way I am suturing this. So that takes care of a small bit of oozing which is there due to a raised blood pressure intraoperatively because of the anesthesia or because of the patient having some pre-surgical condition which cannot be avoided. So that's it. As you can see, I crossed my caudal stay when I came from cephaloid, and now I can just go take 1 or 2 or 3 throws here, mostly of a surgical knot, which we usually, so these are the 2 throws and now 1 with the surgical knot. So we are pretty sure that we have completely closed it. So that's it. This is the end of the anastomosis. It's a single layer anastomosis with the band. As I said, that we place the band 2.5 centimeters below the EG junction. And then this pouch was around 5.5 to 6 centimeters. And the breadth of the pouch is around 2.5 centimeters and around 3 centimeters above the anastomosis. So that's it. Now I'm going to close the Peterson space. That's important in a teaching case because I have seen surgeons not closing it. We had internal hernias through that space in the past, and we absolutely close it. Now I have a different technique of closing it, and it's a little trick which I follow here. So what basically we do is that the first step to close the defect nicely is to expose it properly. So what I usually do is to make the patient supine. Then I hold the colon here by its attachment and just rotate it towards the stomach. So you can see I have a nice visualization of this space here. And then what I do is I take I use my assistant's help, and I take a stitch which is already having a knot. So this, avoids taking knot again, and it gives me and makes my other hand free to just rotate this up towards the stomach. So that exposes the entire defect for me. And this technique we borrowed from robotics, and then we started following in our laparoscopy because robotics has minimal assistance. So what I did was I used to rotate it like that towards the stomach. I used to take it towards the stomach, and then I have this nicely exposed Peterson space. So this we started following in laparoscopy, and now we see that it makes our job very, very simple. So you can again change your retraction. You can keep on changing it. And I have nice two edges, one of the mesentery of the small intestine and one of the mesocolon, both of them visualized in front of me just by doing this little bit of retraction. So I take, again, here the same principle. We are not interested in a very airtight closure, but all what we are doing is just trying to create very nice adhesions between the mesentery of the small bowel and here mesocolon, just so that we, do not have chances of internal hernia. So that's it. Here also the stitches are not very, very deep, not very superficial also. We want them to stay there. So that's it. This is the closure of the defect. The trick, as I said, rotate all that colonic mesocolon up towards the stomach so that you get a very nice exposure. So you can see this is good exposure here. Most students face problem in exposing it. That was the internal hernia closure, and that's the jejunojejnostomy there. Nicely lying, that's the gastrojejnostomy. I'll have a head up now, and I'll fix this ring with the same suture I used for the internal hernia closure. So I have this here, and I fix it up here around 2.5 to 3 centimeters below the EG junction. So that's fixed. And now I'm going to come in with an endoscope because our anesthetist was not able to pass in the bougie. So I'll just come and do a double check for you. My assistant is going to block that end, the other end, with a stapler so that we have a good control of carbon dioxide and that does not reach. Also, I would like to express that, I did an intraoperative endoscopy, but nowhere you could find any dilatation in the bowel. So which means that all those who do intraoperative endoscopy and are scared of not doing it because they might cause a lot of dilatation of this bowel are actually wrong, because that's not the case. We are easily able to do it in our center, and you see that there is no dilatation of the bowel either. So here I am into the esophagus. You can see a little bit of blood in the esophagus, obviously, because we had some oozing. Now I'm going inside. So that's the pouch. This is all clotted blood, what I see. I'm going to do a little bit of irrigation here. When we have clots, it sometimes gets difficult for us to pass through the anastomosis, but now you can see that I have gone through it. This is the anastomosis. Okay, you can see the bowel now. So that's my limb. I've gone into the bowel, and that's the small candy cane which we have. Now I'm going to take the scope back for all of you to see what's happening. So that's my anastomosis there. It's nice. It's not bleeding. There's a little bit of oozing there, but the clot has already formed. So I'm not going to go and disturb it. I'm just going to suck the entire air, come back, and that's the end of the procedure. If there are any questions, I'll be more than happy to answer.
Thank you, Mohit. It's open for discussion for the various faculty members. If they have any questions, I'll take the privilege of asking Cynthia first.
Hi,
Dr. Borg, any questions, comments?
In your practice, what sort of differential weight loss would you get with sort of doing the pouch that way and the same things, and regarding banding and non-banded operations? I mean, what difference do you see in patients' eating behavior and maybe even in weight loss?
So Cynthia, we published this data, 5-year results of our banded, non-banded gastric bypass. We have around 25 to 30% difference of weight loss at 5 years. The same was observed in banded sleeves. So that's as far as the weight loss is concerned. There's a 30% difference, which is huge. And that corroborates with what Fobi, Dr. Fobi and Professor Brookwell published in their meta-analysis. As far as the eating habits is concerned, yes, these patients are not able to take a very large volume of meal. So if I sit with 2 of my patients post-gastric bypass 5 years down the lane, the one with the banded gastric bypass will have still the same amount of small quantity or volume or portion size, but one with a non-banded will eat like, 3 times the amount, because most times they have a dilated candy cane or they eat into the limb. But in the banded counterparts, we don't find that bulk of eating. But yes, having said that, these patients, they have a little bit more food intolerance, around 2 to 5%, as compared to the non-banded counterparts. They have, some patients have a little bit of dysphagia. Again, that is 0.5 to 2%, and we published all these results. But in long term, if you see at 5 years, 7 years, 8 years, they maintain their weight in a much better way, and the difference is around 30% of weight loss.
Thank you.
Scott,
do you
any
recommend banded bypass in all patients or in selected patients, such as binge eaters?
No, we ban all our bypasses, most of them. I have not done a non-banded gastric bypasses since a long time now. So our data suggests that it's a better operation. So why not banded? If the patient cannot afford it, we put a band like I put today. So we banned all our patients.
Thank you.
It doesn't make sense if you have a data which suggests that it's better to do this operation.
Dr. Mohit, congratulations for the very nice surgery. I have a question. If you have a patient with his main aim is the longest diabetes remission, and his BMI is about 40, and his diabetes is less than 3 years, with hemoglobin 1C is less than 7. So, but his main aim of the surgery is the longest duration of remission of diabetes. Which procedure would you offer him? I know your algorithm, but
yeah. So as per we'll go by our algorithm. We offer a banded gastric bypass to these patients because we feel that we give a mini gastric bypass in diabetes when it's very severe. So if the duration of diabetes is more than 8 years, if the patient is on a very high dose of insulin, there's a very strong family history and a poor insulin reserve, those are the cases where we go for a malabsorptive mini gastric bypass with a longer BP limbs. But otherwise, a banded gastric bypass is good enough for the kind of diabetes you're mentioning.
Would you modify the length of the biliopancreatic limb, making a little bit longer to make it?
So yes, when the diabetes severity increase, we go up. We have gone up to a 150 centimeters of a BP limb, and the results are very good. What we decided, and Dr. Fobi has taught me, that if you have a BP plus elementary limb less than a 200 centimeters, you shouldn't be bothered about a less common channel or a malabsorptive common channel. So if I need to increase the strength of my procedure for diabetes, I go a little bit higher on the BP limb, as you said.
Do you routinely dissect out, measure the entire length of the small bowel when you do these cases?
No, because we never bypass more than 200, so I've never done that.
Because I was very impressed, having looked this up in the literature recently, and that in one study that had done several thousand one-anastomosis bypasses, he went back on about a dozen patients for other reasons. And while he was there, he measured his 200 centimeter afferent limb, which was his custom. And 60% of them were much greater than 200 centimeters. One was 400 centimeters. So our ability to measure the bowel is inaccurate, and bowel length varies so much. So I was curious to ask you that, because you could have a patient that you give a standard 200 centimeter afferent limb and they can get into severe nutritional problems.
No, we do not measure it routinely. No, that's not. We try to keep the entire length less than a 200, even if we do a mini bypass. Like mini bypass at this center are done at 180 centimeters. So we expect a margin of calculation of around 10 to 15%. So it can be around 150 or 210, but we don't measure the entire bowel length.
For a vegetarian, would you make it 1 meter or 1.5 meters? For a person who doesn't eat meat?
I think we have standardized our limb lengths to 180 centimeters for a mini gastric bypass, and for a gastric bypass to 80 and 100. So that's what we do now. We don't change them quite frequently.
Gotcha.
Okay.
Mohit, you're probably
Vivek?
one of the only
Go ahead, Dr.
centers-
Please go
you're
ahead.
probably one of the few centers in Asia who actually uses heparin or chemical antithrombotic prophylaxis at surgery. Any issues? Have you seen any issues with that?
No, there are not issues in all the patients. Some patients are oozy, like this one, this oozing sometimes, and mostly it's related to blood pressure. We have a very high blood pressure intraoperatively because of anesthesia issues, and that's the reason why they ooze. With heparin, we never had a lot of issues. Sometimes they do, but it's just.
And how long do you continue it?
48 hours.
How long do you continue anticoagulation for?
Yeah, that's what I'm saying.
This
We continue it
prophylaxis
for 48 hours in the hospital, and then we basically discharge them until unless the patient is completely bedridden. For completely bedridden, super obese patients, we continue it for a month also. But for patients like this, mobile, who can hydrate well, can mobilize, we just give for 48 hours and discharge them.
Okay, great.
Okay.
Great.
Dr. Bindal, any questions, comments? All right. Thank you all very much. We've had a very nice session. There are a few questions from the audience, but we have reached our time limit. We're 12 minutes beyond our time limit, so we would call this quits. We would answer the questions on the website. And at this time, we'll talk about the promo for the next VBU next week on the 15th of February, I believe. Himanshu?
Yes.
Thank
yes,
you,
yes,
faculty
sir.
members.
Yes.
Thank you, everybody.
Thank you. Thank you.
Thank you.
Thanks.
Thank you. Thank you.
Thank you.